everyone. Welcome back to another episode of Ascend TV. I'm your host, Dr. Leslie Cadet. And at Ascend, we help self-insured employers lower their workers' compensation costs by looking at their claims and giving them roadmaps on how to accelerate closure of the claim, right? So today, we're going to be looking at an interesting case of a gentleman who got a staple in his hand. It's a staple that holds a box together, right? Kind of stabbed him a little bit. And for most of us, that's not a big deal. You get over that within 48 hours, but that's not the case in this instance, right? So this is a 57-year-old gentleman who was stuck by a staple and he started to have left hand pain. Now, this happened on the 9th of December, but he didn't go to get medical treatment until the 21st of December, right? So there's a significant delay there in seeking care. The wound ended up not healing because the patient had an underlying condition, which we'll get into. And as a result of that, this claim has stayed open for over 6 years and has cost the employer $659,000 to date. And so Ascend was hired to go through the chart and figure out, is this case salvageable? Why has this case gone off the rails like this? Now, for this type of injury, it typically takes within 2 weeks for it to heal. It should cost the employer no more than $2,700. And so because the person was first evaluated on the 21st of December, we would expect that 2 weeks later, it should be all better and we can discharge the patient. But no, the claim stayed open for over 6 years, and we're going to talk about why. When the worker got stuck by the staple, he didn't go immediately for medical care. It got infected. And so he went to the emergency department, had an incision and drainage, and was given antibiotics. This did not resolve the symptoms because the worker had an underlying condition. He was immunosuppressed because he had had a kidney transplant. When the wound wouldn't heal, a biopsy was done and he was diagnosed with pyoderma gangrenosum, which is a skin disorder we'll get into momentarily. He then underwent hyperbaric oxygen therapy to heal the wound. He had over 50 of those treatments in a small amount of time. But unfortunately, that led to visual complications. So he was referred to ophthalmology, where it was noted he had developed cataracts as a result of the hyperbaric oxygen, and cataract surgery was recommended. This is within year 1 of this claim being open. The worker was referred to dermatology. He was started on Humira because we want to try to avoid the side effects of chronic steroid use. He was then referred to a vascular surgeon because it was noted that the wound still was not healing well. He had an AV fistula. Part of his kidneys failing, he needed an AV fistula so he could get dialysis. So this vascular surgeon says, I think the fistula is stealing blood flow from the hand. If we remove the fistula, he might have better blood flow to his hand. So he has surgery to remove the fistula, and he did have some improvement in his healing, but not completely. So they decided they were going to close the wound by doing a wound flap. That was successful. And as that was healing, we're just on the cusp of beginning to do some physical therapy, get strength back in the hand, and we could try to go back to work. Well, the worker started to complain of swelling in his ankles and back pain, and the treating provider told him to delay physical therapy until they figure out what's going on with the ankles and the back. If someone in the comments could explain to me why swelling in the ankles and low back pain is an indication to not do therapy for the hand, please let me know. I'd love to understand that thought process. The worker was then transferred to a different primary treating provider, and it was at this point that the case started to go off the rails because this treating provider said, hey, I think your kidney disease has gotten worse because of medicines that you were prescribed, and that's industrial, and so I'm going to refer you to a nephrologist. Now, that may be true. We don't know yet. But rather than send this person to some nephrologist that he's never met, why not have him follow up with his nephrologist, the person who knows his medical history, so that we can determine, is he actually having difficulty with his kidneys? Because maybe he's not. So rather than, again, adopt this diagnosis and try to cram everything under industrial causation, let's just take a second and figure out if he's even having a problem with his kidneys. Later on, the worker has an MRI of his hand. He has the wound flap, but this area is still having difficulty healing because of his pyoderma gangrenosum. And so he ends up having an extensor tendon rupture or a tear. So now he needs to get that fixed. And part of that is because the skin has been open for so long and there's been a lot of exposure over time. Because at this point, we are 2 years into this claim. Later on, the primary treating provider diagnoses the patient with a thoracic spine fracture and says this is due to chronic steroid use because of osteoporosis. And he said this is a result of your hand injury. Okay? Again, this represents a deviation from the primary focal point of this case. What evidence do you have to suggest that a thoracic spine fracture is the result of his hand injury? And so now we're chasing rabbits. The worker went on to have a QME for his hand by a dermatologist, and the dermatologist said 100% all of his problems are due to his industrial injury. There's no need to even look at pyoderma gangrenosum. He then had a second opinion or a second dermatology QME, and that QME said, well, wait a minute, 50% of this disability is due to non-industrial immune system factors, his pyoderma gangrenosum, and then 50% is due to the work injury. That seems a bit more fair. The worker was then seen by an orthopedic hand specialist who said, hey, the pyoderma gangrenosum, it has caused skin loss from the dorsum of the hand, leading to this tendon disruption, and he needs surgery. Surgery was approved, but the worker said, I don't think I want to do the surgery with you. He had seen another orthopedist. He also didn't particularly care for that provider either. And so we're at a standstill for getting surgery on the hand. The worker then had an ophthalmology QME. And at this point, we are 4 years into the claim. And the ophthalmology QME says, hey, this person has had multiple hyperbaric oxygen treatments for his wound that has negatively impacted his eyes. He needs cataract removal surgery. So even though the QME said that, utilization review did not approve the cataract surgery until 3 years later. So again, what is going on that we are not tracking our cases closely? What is going on that recommendation could sit in a holding pattern for 3 years before any action is taken? It doesn't make any sense, right? So then the worker sees his primary care provider again, who does his final evaluation and says, 100% of everything that you have is due to the staple in your hand. The worker then saw another orthopedic QME who said, well, wait a minute, steroid use during the treatment period, I don't know that led to his thoracic spine fracture because the patient had been taking steroids chronically for other conditions, such as ulcerative colitis and his organ transplant. That it was true that some of the immunosuppressive medications could cause some musculoskeletal side effects, but I don't think that we can say because that was happening at the same time his hand was going on, that the hand is the reason for the thoracic spine fracture. And Ascend agrees with that and applauds that recommendation. Okay. Sometime later, the worker saw another orthopedic surgeon who also opined that the thoracic spine fracture was chronic and it wasn't caused by his employment. On year 6 of this case, the worker's primary treating provider opined that the worker was permanent and stationary. And at the time we did our review, now 6.5 years in, still had not had his cataract surgery. So let's talk a little bit about this pyoderma gangrenosum. It is a skin disorder that's characterized by inflammation and ulceration because there's dysregulation of various immune responses. There's also genetic factors involved. More than half of these patients with this skin disorder have some type of underlying systemic disease, such as inflammatory bowel disease. And this patient had ulcerative colitis, which is a type of inflammatory bowel disease, and had undergone surgical resection. This worker also had kidney failure, but we don't know the specific reasons behind the kidney failure, but we do know It necessitated a kidney transplant and required lifelong use of immunosuppressive medications. All of this caused the perfect storm because pyoderma gangrenosum can develop at the sites of trauma, such as a puncture wound with a stake. But because the worker's immune system was already compromised and then he delayed in seeking care, the wound became infected and was extremely difficult to treat. Complicating that was the presence of this AV fistula, which was stealing blood flow from the wound. So now you've got to get that removed. That's all interfering with the patient's recovery. And then because of poor wound healing, you end up having rupture of a tendon in your hand. But the worker, per the medical records, does not want to pursue surgical treatment. The worker was on a variety of medications throughout the treatment course, and the primary treating provider is suggesting that one or more of these medications may have negatively impacted his kidney function, but at no point did anyone get the records from the worker's nephrologist. Okay, so our recommendation to our client was, yes, this case has certainly gotten out of hand. It has deviated off course multiple times, and we need to do a couple of things. Number one, we think that apportioning 50% of the disability to his industrial injury and 50% to the pyoderma gangrenosum is fair. The reality is closer to 90% of all of this gentleman's issues are due to underlying conditions that he had before he ever got stuck by the staple. We'd also recommend that the nephrology notes be obtained so you can figure out what was truly caused by the industrial treatment and what was not. We think the worker should get his cataract surgery. And how can that recommendation be made several years ago, but utilization review only recently has approved the surgery? Who has dropped the ball there? So it's really to an employer's advantage to have people working on the claims who are actually tracking them and paying attention to what's happening over time. It's really amazing to me how many people can be looking at a claim but still the big picture is being missed. How helpful would it be to an organization to have someone provide medical oversight for these claims and just kind of track and walk along with the claim? And when things start to deviate or go off course, raise the flag and then initiate corrective action. Had this employer had someone like an Ascend to come in and monitor the claims and make sure that things aren't going off the railways, they would have saved easily over $500,000 on this claim. How much is it worth to have a list, right, of providers who understand the interplay between industrial and non-industrial factors, and we can elevate those providers and say, hey, these are people that we really want to send our injured workers to because they get it. Not only do they care about the patient, not only do they have an excellent bedside manner, not only do they know how to explain things, even the things that are hard to hear, in a way that the worker doesn't receive it as some type of punishment, but can actually navigate our patients to where they get better faster, and these claims aren't being litigated. The claims aren't staying open for 6 years. So if you need help in your organization with monitoring your claims, you've got a lot of these rogue claims. There's some information in the show notes that will be helpful to you because we are compiling a list. We are a nationwide organization, but a lot of our work currently is in Southern California, and we are compiling a list as we're going through these medical records and we can see which providers get it and which ones don't. We are developing a curated list that we can share and say, hey, first report of injury is here. We need to send this worker somewhere. Look, this person is in your MPN and they're amazing. So I hope you found this episode helpful. Like, comment, subscribe, and we'll see you on the next one.